So PBMs decide which medications are covered by health insurance plans, which pharmacies patients can use, and all are owned by insurance companies who in turn also own the pharmacies. And the discounts acquired by PBMs, known as rebates, are often not passed down to the patients. In other words, a PBM could get a $100 rebate from a pharmaceutical company, pass along the $15 to a patient, and pocket the remaining $85. Meaning the insurance company is forcing a larger copay on a patient so that they can pay themselves more than if there was no rebate at all. It's really a system beating down on the patients, and that's who we hear from. So, Mr. Baker, how could we require PBMs to pass through the discounts from rebates onto the patients and avoid insurance companies jacking up the premiums because they're losing profits from these rebates?
That's a great question, and I think it goes back to the theme of the conversation here today, transparency and data. To make sure that at that claim level, the ultimate plan sponsor can see exactly what is being charged, what they're getting back in rebate dollars from the pharmaceutical manufacturers in aggregate. But I think you also bring up another very important point about the PBMs owning their own pharmacies and having that control. Just for perspective, a drug cost is not a drug cost, and this is where we've got to look at that, major corporate umbrella that these PBMs are part of. For example, Mark Cuban's Cost Plus Drug Company, there's a drug called imatinib. You can buy it from him for a year's supply for $866. There's one PBM that works with 4 large state health plans. If you are part of the state health plan of Kentucky, that drug's going to cost you $26,000. If you're part of Louisiana's health plan, it's $57,000. If you're part of Georgia's health plan, it's $170,000. And if you're unfortunate enough to be a taxpayer in Tennessee, you're paying $212,000. Exact same drug, exact same PBM. The price changes depending on how they want to do that and the arbitrage that's in the middle, how they want to move that money around.
I appreciate the answer, especially being here today, given that you're competing industry dominated by the monopoly. So how can Congress disrupt this vertical integration in the industry so that insurance companies can distort our healthcare system and force devastating costs on what I would call vulnerable Oregonians?
I think the vertical consolidation has been 5 years on and is very obviously not helping. Costs continue to go up and quality continues to go down. I think really delinking how PBMs make their profit from a percentage of acquisition cost and sales cost, because then if I'm a PBM and I make 7%, do I want to make 7% off a $5,000 drug or off a $50 drug? And again, these are large corporations who are driven to profit. So, I think it starts with creating the right incentives, getting the right data out there, and then making sure that all of that is completely visible.
Thank you, Mr. Baker. Let's move now to the relationship between PBMs and employers. A whole lot of employers have said they're not able to get accurate cost and pricing information, as was stated earlier, from PBMs despite laws which mandate the sharing of this information. PBMs deny this claim and say that employers can receive cost and quality information at any time through the audit. It seems almost coy, really, for certain PBMs to say, if you want to know whether we're following the law, audit us. Knowing small businesses don't have that kind of time, let alone really the resources to do so. So with that disconnect, Mr. Baker, answer me this. How can we bridge this issue so that there is seamless transparency between the PBMs and the employers? And then to follow up to that, Ms. Monahan, what can Congress do to make sure that PBMs comply with the law and meet their reporting requirements, ensuring the disclosure of direct and indirect compensation for their services? I'll wait for those because I'll be running out of time, so make it quick.
And I'll go very quick. I think it goes to the status quo. Basically, PBMs say you can't audit, but then they say only certain auditors can come in and only certain data is available. So the term audit is very loose and it's not as comprehensive as it needs to be, and it should be able to be done by anybody that the employer chooses.
Thank you, Mr. Baker. Ms. Monahan.
This committee sent a letter last December encouraging DUL to issue guidance clarifying that the service provider compensation disclosures apply to PBMs and TPAs. And at this point, that guidance hasn't happened, but so further action may be warranted to make sure that's clear.
Great. That was quick. Thank you. Doctor and Ms. Tripoli, but I don't think we're going to have time. If PBMs disappear tomorrow, how do you believe employer health plans would be able to negotiate those drug prices with pharmaceutical companies? I know the answer will be long, so I'll go ahead and ask this question to the chair, submit it, and I appreciate, I just wanted to get that for the record, and with that, I yield back my time.